Assalamu alaikum. Good morning, good afternoon, and good evening, depending on your time zone. I hope everybody is doing great. So today, uh, we are going to have a quick orientation about the mock exam, and also in general, I'm going to provide you with the information about the NAC OSCE examination, that what should you expect in real exam as well. All right, it's more like a general information about the NAC OSCE. So sometimes if you hear about somebody that who fails the NAC OSCE, trust me, it's not about their knowledge. It's not that they are like not knowledgeable or uneducated people. It's just because they get surprised and they don't know what to expect once they go there. By the time they are adjusting or adjusting themselves, it's going to be too late because we are going to be timed, right? So this is this is where Jala Academy comes in and tries to simulate mock examination so that you guys get familiar with the structure, with the rules, regulations, and feel the pressure and the tension that you might get in a real exam, and most likely you will. And this way you would be prepared and you know what to expect, what not to expect. So, why this orientation matters? To understand the real NAC OSCE structure, know what examiner reward you, and avoid the preventable errors, right? So, have the OSCE with a fixed station, standardized participant and trained examiners, criterion reference pass-fail standards. This comes under the understanding the real NAC OSCE structure. Also about the second one is know what examiner reward you. Most of the time, we don't even know what are the things that we need to focus on or work more on or improve on so that we get more score. So this is this orientation for safe clinical priorities, clear communication and professionalism, structure, efficiency, and good judgment. Safe clinical priorities, like how do we have to deal safely with an station? The examiner is not only looking at us that if we are a doctor or not, if you're knowledgeable or not, they're actually looking if we are dealing with that station very safely. If we know that the safety comes always first. By safety, I mean it's not only about the safety of the patient, the safety of myself and my team. So if we prioritize the safety in general for myself, my team, and for the patient, we should be good. Clear communication. Sometimes we try to race against the time, and I don't blame anyone because that's the most challenging part of this any station to beat is the time management. But sometimes we speed so much that our communication is hard to understand, especially when it comes to consultation. When we are counseling the patient, remember, we are not there to lecture the patient. We're there to educate the patient. So it means all our communication supposed to be in a lame language, very understandable. It should be crystal clear. I know a lot of IMGs, they're really, really knowledgeable. Like they're specialists, they know their thing. So once they start, I cannot catch them. Like it's so hard to understand them because they're talking so fast that's impossible for anybody to understand them. That's not what they're looking for. They're looking for a clear communication skill for a few reasons. One of the reasons is that your patient is in pain. It's very hard for somebody who is in pain to concentrate. Secondly, we are going to practice in a country where most of the patients are immigrant. So most of our patients might be speaking English as a second language, not as a first language. So we need to we need to speak very clearly to make sure they understand what we are saying. Okay? And professionalism, of course. I'm talking for myself. I have seen a lot of people from my back home country that they are doctors, but they are not professional. Like they're really, really knowledgeable people, but the way they're acting or the way they're behaving with their patients, some of them are not professional. But here we have to be very professional. So that's what matters. If you want to pass the exam, you need to be very clear. You need to have very clear communication. You need to be very professional. You need to prioritize the safety of yourself and the patient. And you need to have a structured approach in every station. When I say structured approach, I mean that you can always do the station and ask the patient date of birth at the end of the station, right? At the end of the station, you can also ask the patient, what's your name? May I have your date of birth? You covered it, but it's not the structured way to do it. It's not like A, B, C, D. It is like D, C, or A, or B. It's disorganized. It doesn't mean they're not going to mark you, give you score. They will score you. They will give you score, but not 5 out of 5. They're going to give you 2 out of 5. So in order to be scored properly, so you need to be structured. Start from A, B, C, and finish it to Z or Z. So efficient, good judgment. When I say judgment, I don't mean to be judgmental because the patient has some sort of or a specific habit. I mean judgmental based on what might be the diagnosis. Based on this condition, this might be the diagnosis. Based on this finding, this might be the diagnosis. But we never judge the patient based on any habit, whether it is good or bad. For example, if someone says, yeah, I'm drinking alcohol, it's not much, like, okay, can you be a little bit more specific? Like, how many drinks do you drink? Like 20 drinks per day. You can't just judge the patient based on his drinking. Like, wow, that's a lot. It's completely different thing. I hope it makes sense. Avoid preventable errors, missing red flags, or urgent escalation. For example, you're taking history, but the patient says, I cannot breathe. And you're like, give me 5 more minutes and I will be done. The patient has tension pneumothorax, or the patient has pneumothorax, or the patient has hemothorax, or the patient has spleen rupture, and the patient is about to go to coma. But you're insisting, just give me 5 minutes, right? So the urgency, if you know that the patient requires escalation, we need to escalate it. Or missing the red flag, for example, you're dealing with a back pain, but forgetting to ask the patient if the patient has subtle anesthesia, if the patient has any bowel or bladder movement dysfunction lately, or if the patient has lost sensation in the inner and outer area of the thigh. So these are the things that we cannot miss. If you miss a red flag, trust me, this is heavily scored. If you miss it, you miss a lot of score. Breaking station, timing or task focus, and poor exam day conduct or confidentiality. So we need to pay attention to the station, whether it is a station that we need to break the bad news, how we should change our tone, how we should talk, how we should deal with the patient, or how to conduct the whole station in general. Do we have to provide the patient with the confidentiality or not? So if you're dealing with a complicated station that you don't even know what is this station, try to provide them with the confidentiality. See, probably that is an abuse. See, that might be an some sort of condition that the patient cannot trust you to open up until you give him or her the confidentiality. For example, she has headache, but it doesn't match any clinical picture of any headache. It's very vague. The patient does not have eye contact. So provide them with that confidentiality. Everything that you said here will be strictly confidential. I will never, ever disclose it to anyone unless it is asked by law or by yourself. Then the patient will open up and give you all you need. The real NAC OSCE examination, how it's going to be. Half day OSCE, it's going to be half day. In total, it's going to be 12 station, but 10 of them is going to be scored. So two pilots a station. Between the station, there will be 2 minutes. That 2 minutes not to take break. That's 2 minutes that you need to go to the next station, get the next station instruction, read it, come up with a structure. For example, if I'm dealing with a back pain, how should I start? How should I finish? What are the red flags? What are the differential diagnose? And what are the things that I have to rule out immediately? So let's say, for the sake of this orientation, let's say you're dealing with a back pain. So with a back pain, I would start with the OCD PQRST UV triple A. I cover that, then I will go with the review of the system. Then I do a transition to the constitution sign and symptom. Then I do a transition to the past medical history. Then I do the transition to family history. Then I do a transition to the social history. Then I summarize it. Between the review of the system and constitutional sign and symptom, I would cover the red flag as well. Or while I'm doing the OCD, I can cover it. All right, so this is how you come up with the structured way of approaching the station, and then you go in and you will not screw the station. You will be really, really confident and you know what to do. Whatever you ask, you tick mark, you tick mark, you tick mark, you tick mark, and you're done. At the end, I did all this and you will be fine. Okay. Otherwise, you're going to be all over the place. You don't know what to ask. You don't know where were you. You might ask one question like a few times. The patient will have already answered you, but still you're asking the same question. Why? Because you're not structured. So please have that note and the structure ready before you enter. That 2 minutes is vital. Okay. Registration, orientation, class orientation. Remember, arrive early. If you're late by 15 minutes, you will not be allowed to attend the exam. If you check the branch, the examination branch, it is 1 hour away from wherever you live, I would encourage you to leave at least 2 hours early because it is hard to predict how the traffic is going to be on that day. So make sure that you are at least 1 hour and a half early. If for any reason you get stuck and you're late by 15 minutes, that's it for you. They're not going to allow you in. Okay. And you don't want that to happen. Trust me. A station cycle is 11 minutes per station. If you don't see it, that's 11 minutes. Okay. It is for all the station, 11 minutes. Reading time, again, 2 minutes to move and make a structure. Wait station, sometimes it happens, not always. In some branches, it may happen, not always. 2 to 3 non-scored waiting station may be included. So that synchronize that circulation and kind of keep everybody attending their station, okay? So total center time, about 5 hours, including sign in and sign out. So in total, it will be 5 hours. That includes the sign in and sign out. Remember, before you sign out, you need to submit all the paper, the short notes, whatever you have received from them. Please do not forget to give it back. Submit it. If you leave by any chance and you forget it and you just left unconsciously having all those documents or notes or whatever, they will disqualify you. So please do not forget it. Please submit it and then leave. Okay. Do not even carry one pencil with you. Whatever you get from them, give it back to them. And you don't want to be disqualified. So disciplines in the exam. So most of the IMGs were asking me that what are the disciplines that is going to be in the exam? It will be medicine, it will be surgery, pediatrics, obstetric and gynae, psychiatric, preventive medicine, and public health. And the preventive medicine and public health is also included the ethics, just to clarify that, okay? So up to 7 competency can be rated in a station. History taking, focus, logical information gathering, diagnosis, reasonable, differential, and clinical synthesis. Remember, for the diagnose and differential diagnose, sometimes they might ask you about the differential diagnose. Don't just name. Okay, for differential diagnose, the minimum is 3, the maximum is 5. The minimum is 3, the maximum is 5. Never go with a 5 because you don't have time. Go with 3. Whatever is your 3 differential diagnose, put the most likely diagnose first, second, then third. But you have to justify every single one of them. If this is my first differential diagnose, what is my justification for this? Why did I choose this? Based on these findings, based on these things that my patient mentioned, it is most likely to be, for example, acute appendicitis. And second, I put this as a second because this patient has all this, but not this specific finding. Okay. And the third one, likewise, management, save next step, counseling, follow up. You don't want to miss that. Communication skills, patient centered, clear, respectful, physical examination, focus exam with explanation and modesty, investigation, appropriate tests and prioritization, data interpretation using results accurately in the context. Sometimes you may get a station that the patient has this and that condition. When you get in, there will be a lab result ready for you. Then you can read that, and based on that, you can start the counseling. How scoring works. Official scoring facts. Each score station is worth the same as every other scored station. Your total score is the average of the 10th scored station scores. The score is then statistically linked to account for exam form. Sorry. From difficulty, reported total score scale is between 500 and 700, but the pass score is 577. If you're anywhere less than 577, fail. If it is above 600, you're really good. But if you're more than 650, it means that you will 100% get a call for residency. Remember that passing the exam is one thing, but passing with a good score is another thing. I'm pretty sure you have heard a lot of IMGs, a lot of doctors, they have already secured the exam, but none of them are receiving any call for residency. They cannot find any placement for residency. And the reason is that they just barely passed. The residency is very competitive. You don't want to pass. You want to pass it with a really good score so that you pass it and get the call for residency. You don't just want to pass, because passing doesn't matter if it is just like 577 or 577, right? It doesn't matter. It's as bad as not passing it. Why? Because every position that you apply, there will be a list of people. Let's say if there is 10 candidate for one position and one of them is 100, let's say, like, if you have somebody who has 100 and you have for example, 57. Who do you think is going to be picked? And if I put you as a, let's say, head of that hospital, who do you pick? Obviously, the one who has 100. Who would be your second pick? Somebody who is 90, who has 90, and who is going to be your third pick? Obviously, somebody who is 80 or 85. Are you going to be going for the person who has 57 or 62? Obviously not. So this is how it works. Try to not only pass the exam, pass it with a really good score so that you secure the residency as well. Okay? In order to do that, just to give you a very general information, treat every station like you're a family physician, a resident. Do not treat it like you're a student. If you treat any station like a medical student, you will definitely fail it. You need to have that confidence. All of you are professional doctors, so you need to act as one, and you need to deal with the patient like a professional healthcare provider, not as a medical student. Sometimes unconsciously, since like IMG has exam, they switch. They switch the brain and they act like a medical student. And this is how they fail. Okay? Act like a family physician, like a resident. Don't act like a students or medical students. So most of the scoring, like 70% of the time, is based on the assessment and diagnosis. When I say assessment is physical examination plus diagnosis. Management, 15%, communication is 15%. So in practice, examiner uses standardized scoring instrument that can include key feature checklist, oral question answer keys, rating scale for the relevant competency. Safety first. As I mentioned before, safety, it doesn't mean that we have to always think about the patient's safety. We have to think about our safety first, then the patient's safety. Why do I say that? For example, if you are having an station that is suspected to be infectious, as soon as you enter, introduce yourself, ask for PPE for yourself and for your team. For example, you have a patient that who is vomiting blood, or somebody that who is suspected to be very infectious and coughing. So I would like to have PPE or personal protective equipment for myself and for my team. Then the safety of the patient comes. Another example, for example, you have a psychotic patient. The patient is very combative. The patient is throwing things, right? So my safety comes first. Then the patient's safety comes second. So I don't approach him until I know it is safe to go inside. Okay? I need to take a few people with me. If I know the patient is throwing things, I have to call for the security. I have to make sure that I'm safe. I have to make sure my team, who are the nurse and physician assistant, they are safe. Okay? I'm not just going to take the risk and just jump in to get punched in the face. And then the safety of the patient. For the safety of the patient, I'm going to give you an example. For example, you are checking for the proximal muscle weakness or myopathy. You ask the patient to make a cross and then stand up without using your arm. So this way, if you do not guard the patient may stand up. If the patient has proximal muscle weakness, he will fall down. So the patient safety is also required here. You don't have to like hold the patient as long as you're acting that I'm here, I'm trying to protect you. Can you stand up for me and just act that I'm protecting you? That shows that you care about the patient's safety. Or when you ask the patient to give you a walk test, so you ask the patient to give you a walk test, and at the same time, you're protecting the patient by holding your arms around the patient, not touching the patient, around the patient, to make sure that if he loses his balance, you will be there to hold him before he hits the ground. And then at the same time, you're reporting your findings. So this is another example. Patient-centered communication, clear language, empathy, confidentiality, no jargon. So remember, medical term or jargon for the examiner, but lame term for the patient. Okay? As lame as possible. I want you to flex your knee. The patient doesn't know what is flex. I want to extend your knee. The patient does not know what is extension. So ask the patient to bend your knee. But flexion for the examiner. Professional behavior, respect, composure, modesty, consent, and boundaries. So draping the patient is very important. So you need to pay attention while you're asking the patient to lie down. So as the patient lying down, you have to drape the patient and expose only the area that you are going to perform a physical examination. Okay? Focus structure. We have already done it in the class, right? So you guys know. Focus structure. Answer the task on the door. Avoid wandering into a full clerking. Okay? Be focused. Be focused. What is the station? Stay focused. Don't do everything. Don't be all over the place. Clinical reasoning, reasonable differential investigation and management priorities. Time management, good opening, concise transition, strong summary, and closure. Remember, the first impression is the best impression. If you start strong, you will 100% finish it strong. If you start very weak, trust me, you're going to screw the whole station. So the first part of the station, the way I like, I don't know if you guys have, like most of you were in the class. So mm, some of times when they start, you know that she is not even comfortable saying these words. You can tell. Why? Because they're trying to find the words, what should I say? I would encourage you guys to do this, like practice as much as possible so that you get so comfortable that once you start, you cover everything, everything. Just change the name, change the condition, and this and that. Just memorize the whole thing. You need to do it at least for the exam. Okay? Bottom line, perform like a safe, organized entry to residency doctor, as I mentioned before. Okay? Like a resident, like a doctor, not like a medical student, not to memorize the script reciter. That is just for the opening. Opening should be very strong. As long as you impress the patient at the beginning, trust me, the whole station will go very well. All right, real exam day essentials. You must bring. What are the things that you need to bring with yourself on the exam day? Plain white lab coat with no university or hospital crest. It doesn't have to have any logo, any name, anything. Okay? If you don't have it, buy it. I think you can find it very easily. But make sure there is no logo, nothing written on it. Even with the pen, if it is written anything, you have to cover it. Okay? A stethoscope that you have to have it. Printed entrance card that is essential and vital to have it. Otherwise, they don't even recognize you. Printed and signed candidate confidentiality agreement page that should be also with you. Pre-approved personal item. So clear water bottle and a small nut-free low odor snacks. But again, I doubt it if you guys need it. Inhaler, if you are somebody that you are taking some certain specific medication, please contact them and let them know that these are the conditions that you are suffering from and these are the medication that you need to have. For example, if you have anaphylactic reaction, for example, for any specific food or nuts or anything, then you have to have your EpiPen and likewise. Hearing aid, if you have a problem with hearing, you can have it, but it shouldn't be connected to phone or it shouldn't have Bluetooth. Eyeglasses, face mask, cane, or crutches. Not permitted in the secure area. Phone, table, smart device, communication device. Watches of any kind. So you don't have to worry. Don't bring any sort of watch to kind of manage your time. First of all, don't do that because if you are training yourself having the timer and looking at the timer, first of all, it's going to distract you and it becomes your habit. Don't make it your habit. Don't worry about the time. You time yourself, but don't look at the time. But when you go in a real exam, you know how you can manage your time. There is not going to be allowed any watches or anything. Not only that, the hearing, like the rings, nothing. No watch, no rings, no earrings, nothing. So you shouldn't be even bothering to take anything. And also, if you have long hair, please tie it up. Okay? It doesn't have to be coming all over to your face. Very unprofessional, and even you might lose mark for it. Documentation, pen, pencil, paper, large bags, coat, wallet, purse, keys, reflex hammer. These are not permitted. Rules, conduct, and high stakes consequences. Non-negotiable rules, like things that they don't even listen to you after that. Like even if you complain that this happened because of this reason and that reason, they don't even bother to listen to you. If you are more than 15 minutes late for the registration, you may be denied entry. Okay? So they don't even listen after that. Speaking to anyone other than exam staff during the exam is prohibited. For the tomorrow and the day after tomorrow, if you're coming, please do not talk during the examination. The station, the whole hall should be very quiet, unless there is an emergency, unless there is something that you need to talk. Otherwise, just keep it quiet, okay? Do not discuss or reveal cases, finding, oral question, or themes before, during, or after the exam. So what was the exam? I don't know. Was it hard? I don't know. Was it easy? I don't know. So you're not allowed to discuss anything or disclose anything from the exam day. If by any chance anyone report you, you will be disqualified. Okay? If you come out and say, oh, I had one station about the back pain and it was like 76 years old, patient had back pain, I think it was sciatica. You're done. If they hear about that, you're done. You're disqualified. So don't even bother. Okay? If you start the exam, it counts as an attempt, even if you cannot finish it. So once you start it, that's it. You cannot leave halfway. So make up your mind. Are you ready? If you're not ready, you can change it anytime. You can do it later, but don't attempt the exam unless you are 100% ready for it. Report exam day incidents and conflict of interest promptly and to the physician apply within 7 days. Anything that happens that you know that there is a conflict of interest, please report it to physician apply. Potential consequences of the confidentiality breaches or irregular behavior, denied final result. Report to regulatory authority or other organization, bar from the future MCC exam, disciplinary and legal measurement. Professionalism includes protecting exam integrity. So before entry inside the station, what actually happens? Before entry, read the door instruction very carefully. Okay? Remember, sometimes it happens that you see the chest pain and you're like, I got this. It's easy. I know what to do. OCD PQRST, UV triple A. I'm good. But when you go there, you start taking history. That is actually for physical examination. So it means do not skip anything, not even a word. Read it. Read it very carefully, all the way until the end. When it says there's no word, then stop. Okay? Read it word by word so that you know what am I dealing with. It's a chest pain. It is a history taking. It's a consultation. It is physical examination. It's management. It's differential diagnosis. Whatever it is, write it down. Chest pain, history taking. Then the instruction. I will enter. I will do the introduction, confirm the patient ID and date of birth, take the consent, explain my role, and start the station. And these are the things that I will cover. Okay. The task setting, patient age, vitals, test result may already be given. Remember that we never start any physical examination without having the vital sign. Most of the time, you will be provided with that vital sign. If by any chance you are performing physical examination and you don't have it, you cannot start it with a vital sign. Please ask for it. May I have the patient's vital sign? And everything is normal, or the patient has hypertension, or the patient has tachypnea, whatever. At the signal, enter immediately. When I say immediately, it doesn't mean just open and enter. Knock. And when you knock, then knock, it doesn't have to be very harsh and unprofessional. It doesn't have to be too soft so that they cannot even hear you. You will be in a better position to tell. So knock 3 times, then open the door with a smile and greet everybody. Then start. Okay? And when you knock, wait for them to let you in. Come in. Once you hear that, then go in. Okay? Sometimes they knock and open the door. That's not the right way to do it. You lose mark right there. So as soon as you start knocking, the clock will start, the scoring will start. So by the knocking, the first knock you do, it is on. So you get the score all the way from there. You don't want to screw it at the beginning, okay? So knock 3 times, wait for them to let you in, then go in, unless you don't hear them, okay? Then you can make it a little harder. They will call you in. Then open the door. Keep that smile always on, unless it is a condition that it's a pain or that and this and that, then you just drop it, right? And keep your tone, or sorry, change your tone based on the condition. But at the beginning, always keep that smile on, okay? Again, unless that is a suicide, unless you're breaking bad news. At the beginning, keep that smile on. All right. Extra time outside the room does not extend the 11 minutes. So it means 11 minutes, 11 minutes. Physical examination station, say what maneuvers you are doing, what you're looking for, and relevant finding. SP stimulus finding, the examiner may prompt verbally. So it means that whatever you do, you need to verbalize it to the examiner. In some cases, remember, first of all, we have to know that the patient is not a real patient. These are standardized patients, they are actor. 99% of them are much healthier than us. They're younger than us, they're healthier than us, they're professional actors, okay? So it means they have no condition whatsoever, specifically the condition that we are dealing with. So we are also acting. It means if there is a maneuver that you think that it might hurt the patient, do not do it. Verbalize it first, get the permission, then do it, but be gentle. If you hurt the patient at any point in the station, that station is done for you. You will fail that station. I'm going to give you an example. Let's say you have a patient and your patient has neck pain, and you think that my patient might have a cervical radiculopathy. Okay, what is the special test for that? Sperling test, right? A Sperling test is very sensitive test. It might cause a lot of pain for the patient, especially for a standardized patient who has no condition in the neck. He's just acting, right? So for that, you know that you extend the neck, rotate to the right a little bit and tilt it to the right or whichever side is affected, let's say right, and then you apply pressure. Please don't apply pressure, just act like it. Just touch the hair, don't push it. Because remember, that standardized patient is going to go through that physical examination, probably if there's 20 candidates, and the 20 candidates will do the same physical examination on him. If everybody is pressing, that patient will end up to the hospital at the end of that day, or at the end of that examination day. So please act. Do not apply too much pressure. Do not actually apply pressure. Just act like it. Act like it that I'm applying pressure, okay? So some of the physical examination that you know that they may cause discomfort or pain for the patient, first, explain it to the examiner that I would like to perform it and see if they give you the permission. Should I do it? And they will say, yeah, sure, go ahead. And then do it. Okay? Not all of them are very painful, but some of them. That was one of them that I gave you an example, a Sperling test. All right? And also, before you're touching the patient, always ask for consent and explain, like, for example, I'm going to put your leg, I'm going to bend your knee, and I'm going to put it on the other side, and I'm going to apply pressure on the knee, and I'm going to stabilize your hip. Is that okay? The patient say, yes. Can we start it? Yes. And at any point, if the patient says, I have pain, stop. Say, can we continue? Are you okay to continue, or do you want me to stop? So if the patient says, I have pain, first question, where? I'm so sorry about it. May I know where? First, you have to know where the pain is. Based on that, you know, like location of the pain, condition based on the location, right? For example, if you do a Faber test, the patient says it's anterior, hip pathology. If it says posterior, where in the posterior? In the lower limb. So it is most likely sacroiliitis, right? So you know based on the location, the condition changes. Secondly, are you okay to continue? Can we continue? If the patient says no, that's it. You can't continue. If the patient says, yeah, it's okay, you can continue. But if you don't mention it, it doesn't mean that the examiner doesn't care. He is waiting for you to say that. So do not think that he knows that, yeah, he's okay, he can continue. No, you have to verbally mention it and get his consent that, yeah, he's okay to continue because he is waiting for you to mention it and get the consent. Then he's going to take mark and give you score. Okay. All right. So sensitive exam, do not perform So for digital rectal exam, vaginal examination, breast, reflex, we don't do it, but it doesn't mean we don't mention it. Okay. Let's say you have a patient that you have to do the digital rectal examination. You just turn around and say, the next exam that I would prefer to do is digital rectal examination. And the examiner will say, skip, but give you mark for that. So do not think that the examiner knows that these are the things that we are not doing it. No, you have to mention it and look at the patient, the examiner, and let him tell you to escape. Then he would be in a better position, and you would be in a better position to say, yes, I got the score. I at least covered it. And also he would know that you know, but you're not allowed. So he would give you a score for that. Station with the oral question at the 8 minutes mark. The examiner may begin oral question. Remember, after 8 minutes, when it's done, sometimes this is how you can tell if you're late or if you did manage your time or not. So by 8 minutes, let's say if you have history taking. So 8 minutes done, then the examiner will start asking you the post encounter question. The last 3 minutes would be the post encounter question. After that point, you cannot return to the patient. And remember, if you finish the station, let's say you're at the middle of examination, you did not manage your time, you run out of time, and the patient is exposed, the ring goes off, don't just leave. Cover the patient first, thank the patient, appreciate for all the support that he gave you during the examination, turn around, thank the examiner, and leave. So do not proceed doing anything. Just covering the patient is part of your job, or positioning the patient in a proper position. Don't just leave them like in a very awkward position or uncomfortable position. You have to put him back like in a proper position that he is comfortable and cover him and then leave. Okay, but do not perform any physical examination. Do not start talking with the examiner, or do not say, I forgot this and that, because when the ring goes off, the 2 minutes that you need to have for the next station has already started, right? And also the examiner with the standardized patient needs 2 minutes. 2 minutes to finalize your station because they need to mark you as well. I'm not saying the standardized patient will mark you, but he will ask him, how did he do? So it means the standardized patient will have a say. For example, he was okay, he was good, or no, he did hurt me. They need that 2 minutes. So don't be rude, go out, take that 2 minutes for your own station and let them have their 2 minutes to have their discussion and give you mark. Okay. At the final signal, leave the station and move on. You may not leave early. And if you're finished, you cannot just leave. You have to wait for the ring to go off. How our mock exam will mirror the real exam. So recommended mock rule for today, 2 minutes. We're gonna do the same thing. Okay, we're gonna do the same thing. You will be provided with the obviously we will give you a paper. In the paper, in the first part on the top, you will have the instruction. For example, you have X or Y as your patient, and then it will specifically tell you what to do. So normally, I will show you an example. Normally, they don't mention this, for example, chest pain or chest focused uh, history. But for the mock exam, we might do it just to help you out a little bit. But in real exam, they don't do that. You just have the station. Yeah, 45, the patient has pain while he's breathing in or breathing out or walking on the chest and this and that. But we mentioned. But remember, at the end, it is mentioned 2 minutes. You have 2 minutes to read this instruction. And then beneath that, in the red letter, it is written that take your notes here. It means every paper that we provide you, that is the paper that you take the notes to structure and prepare yourself for the station. So you have a space there, you have room to write down and take some short notes. And you can turn it around and write some notes at the back as well. Okay. All you need to bring with you is the same thing. Have your white coat, have your stethoscope, and have a pen or a pencil. Please do not have ring and all that. So we're trying to simulate it as much as possible. Do not have your rings on, your earrings, and also the headphones. Please don't do that. And be respectful. And yeah. So 2 minutes, 11 minutes, no coaching. Once timing begins, please do not talk. Once the station is on, please don't talk unless it's something very emergency. Treat every standardized participant as a real patient. But again, remember, do not hurt the patient. If the patient says that you hurt him, the station is failed automatically. Professional dress, no phone, no side conversation. Stop immediately on the bell and rotate. Best way, you use the feedback, score each station by task completion, global performance, record whether the problem was knowledge, structure, safety, or communication. What was the issue? Please work on that. You have still 2 weeks. You can work, practice. The only way that you can get a hold of the NACOSKI and do it as professionally as possible is to practice. Trust me, everybody knows how to do it. It just takes a little bit of time to get fluent, get that flow. So practice, 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 and practice. You need to have your practice partner, at least for the last 2 weeks. We are trying to launch another 2 weeks, really intense uh, crash course for the NACOSKI for those who are attempting in May 2. It's going to be started in April 15 to April 30. So if anyone is interested, please let me know. So that would be a really good chance for an opportunity for you guys to practice more. Okay, we're going to cover most commonly tested topics, and we are going to do not only the physical examination, we do the consultation, differential diagnosis, management, all of that, and history taking. After mock, build 2 to 3 specific behavior change, not 20 gauge goals. So it means those habits that you have, everybody has habits. We are not, nobody's perfect. We are not aware of it unless it is pointed out to us. Someone that who is observing us performing in the station, that is very eye-opening. So listen to them, see how it's properly done. What was the weakest point that you had in this station? Start working on that. And then trust me, it will improve significantly. Practice weak station types again under the same timing. Mock exam principle, realism first, comfort second. All right. So high yield mistakes that cost candidate marks. What are they? Long introduction that wastes station time. So keep it as short as possible, as professional as possible, as fluent as possible. Do not have like 2 minutes introduction. Okay. Just keep it very small, but nice. Doing a full review of a full body exam when the task is focused. Again, same mistakes. Please read the instruction word by word. Don't make a mistake. If you read the chest pain and you're like, I got it. This is history taking. It's very easy. OCD, PQRST. When you go in, and this is all about the physical examination, first of all, whatever you say, the standardized patient is not going to answer. Remember, the standardized patient are trained. They play dumb. They play dumb. Like sometimes you get really pissed at them. Like, why is he not answering? It is not because they are dumb, they're playing dumb. It is because we're not doing the right thing that we are supposed to. For example, It is physical examination. I'm taking history. Obviously, they're not going to answer me because you had 2 minutes. You should know that this is physical examination, not history taking. You should be performing physical examination, but he's not going to tell you. He's just waiting to waste your time. Okay? If that happens, it should give you a signal that something is not right. If they're in a good mood, probably if you have a very good, which 99% of them are good. So examiner, he will tell you, go out, read the instruction, come back. So if you go out, read the instruction, of course you're going to take 2 minutes, right? So obviously you lost 2 minutes inside by being wrong, went outside, took another minutes, 4 minutes. 4 minutes is gone. Now, who is going to miss out this station? You. So that's why, please read the instruction word by word and make them up. This is how I'm going to do it, and this I'm going to finish it, structure-wise. Using jargon or giving premature reassurance. We are not there to reassure anyone or give him a promise that's not realistic. So we are not over-promising anyone anything, and we are trying to be as realistic as possible. We're not using jargon. Jargon is for the examiner. Failing to summarize findings. Remember, always summarize. Always at the end, summarize, okay? Failing to summarize finding, impression, and next steps. Do this instead. Open with the consent, focus, and repo. Repo building is very important. It means anything and everything that the standardized patient is doing, you have to thank the patient. Thank you very much. Can you do this for me? Be very nice. For example, you're asking your patient to lie down. Can you do me a favor? Can you lie down on the bed facing up? So this way, they feel very welcome. And this is building the repo. So if they can trust you, they can give you all the information that you need. If they can't trust you, obviously they are going to be very rigid, and that hurts you. Prioritize red flags, severity, and immediate safety. Use clear structure, assess, synthesize, plan, check understanding, verbalize key findings and clinical reasoning in a focused way. Close strong with a summary, management, and safety netting. All right, final readiness checklist for IMGs. Before exam, they practice with 11 minutes timing. Prepare clean opening and close phrasing. Review common emergency and red flags. Train yourself to verbalize physical exam findings as sleep, hydration, and travel planning matters. So please think about all of them, okay? And the last, if you have the exam on May 2nd, I would encourage you to take the May 1st off. Just relax, rest. There won't be any like significant change if you practice the last day before the exam, okay? Take the last day to rest, because if you are burned out, trust me, it will backfire. No matter how prepared you are, it will backfire. Take the last day off. I mean, the last day before the exam. Okay, but before that, this last 2 weeks, I think this is the best time and very crucial timing that determine how your exam is gonna go. So you need to, if you have a work, please take off. If you have any responsibility, disconnect. Tell them, just give me this 2 week, and then I will compensate. So take that 2 week from April 15 to April 30, practice at least 10 station, 12 station every day, 10 to 12 station every day. Like you have to keep on practicing. And if you happen to join our course, you're more than welcome to do so. If not, but please practice with yourself. I mean, not with yourself, with your practice partner. If you get stuck in a station, pause for one, breathe, like take a deep breath in and out, return to the door task, which usually if you don't, they will ask you, state your main concern clearly, prioritize safety and immediate next step, keep moving, partial performance still scores. Remember that we are human beings. Nobody's perfect. If you think that you're going to go there and you're going to crush it and you're going to be flawless, it's not going to happen. But we are human being, and most of the examiner is, was IMG. So they feel your pain. They have gone through this rough and tough timing, so they can feel you. Trust me. If you make a mistake, apologize for it and start fresh. Okay? With the confidence. Don't like, oh, I screwed up, so I'm done. No. They expect you to have flaws. They expect you to have mistakes. And they know that you're under a lot of pressure. So don't worry about it. Everybody makes mistake. Just apologize for it. Not apologizing will cost you. Like dismissing that is going to cost you a lot of score. Owning it, on the other hand, will definitely partially score you. So apologize, start fresh with a confidence. Okay? Nobody's God, right? We're human being. We're not perfect. Remember, the NAC is designed for the level of a recent Canadian medical graduate entering residency. You do not need to be perfect. You do need to be safe, though. You need to be organized and patient-centered. And that's all about it. Thank you very much. Now, if you guys have any question,